The last presenter before we have the panel is Carmen Sanchez, and I think the clinical nurse consultants, the nurse practitioners, are the linchpins in the motor neuron disease clinics, and they really herd all the cats, that is the clinicians, and get them all organised, get all the allied health people organised, and I really think MND clinics, the multi-D clinics, wouldn't run without them. So Carmen, thank you very much.
So I'm very grateful that I've got invited to us talk a bit what we do. And my presentation is nothing about science. It's all about more day-to-day practical what we do and facing the difficulty together with the people with MND. So what we call it now is a long name, neuropalliative rehab model of care. In the MND Care website, there is a flow chart that show the pathway, how it works. And we're more or less similar to them. The only thing we do differently is that we stick with the PAL care very early on. So we don't wait until the post-rehab phase to start for the PAL care to come in. So just a little bit about Calvary. So I'm from Sydney. Calvary, and we are the Southeastern Healthcare. So we look after the area from St. George to Sutherland area. So we started from the south of M5 near the airport, the runway, and down all the way through Canal, through Bandina, all the way down to Waterfall. So we have a population about 450,000, which is growing because a lot of building and units are building. And so we expected the numbers to be increased as well. So the demand on the service will also be increased. What we do and what we are lucky of is that we already have a pre-exist subacute hospital. So the Calvary Hospital already exists 50 years ago that specialized in PAL care. And then the rehab department started to grow. So we were able to have both rehab and PAL care all under the same roof, all in the same building, and it's purpose-built, and all the experts are all within the building, which is one and only around the area. So that is one major reason why we're able to run the service and deliver the high quality of care that we want because of this. But we weren't able to deliver what we want without the all different acute hospital, the expertise from the neurologist, as well as the support from the MND Association, and also they deliver the actual care to patients' house day to day with all the allied health around. We do depend on the acute hospital for gastro, for put the pig in, to put the BiPAP, sleep study, and all because if it's local or within Southeastern, we were very easy to get able to get access to the notes for the EMR as well. So that put one less layer in between the patient's care. We can just click on the computer and we can see exactly what happened, where they've been in hospital, they've been discharged back home, the discharge letter is all there. So that helps a lot. So how we run our model of care, and we really focus on PAL care focus. So from day one, the patients can just give us a ring, saying that they got MND. So, because no one will going to lie about they've got MND. So they just phone and say they got recently diagnosis or the GP. We do attend the GP breakfast just to let them know our service around. As well as the neurologist referral from Margie, from the BMI, from Macquarie. So all those very detailed information of the patients already given to us from that referral. Also, we find it more and more through the allied health, the OT, someone end up in ED, And then they have the rapid response team saw the diagnosis with MND, and they will give us a buzz that, do you know these patients already? So all that referral come through, and also the MND Association. When they got a new members join and it's not in the list that we send them, they will give us a buzz that whether we know these patients already. So it's really a whole networking to make sure that we don't have anyone through missing from our service. And we make it very first phone call. It will always be myself who make the phone call to the patient. And myself as a palliative trained nurse. And I always make that first contact as therapeutic communication already. A lot of time, there are a lot of tears on the phone, a lot of carer stress expressed on the phone, where they don't know where to go, concerned about the futures. They got this diagnosis, all they saw is the internet and what been told to them from the clinic, and they all gone home and try to process it, digest it, and come up with what I'm going to do next, and try very much to make the conversation end with reassurance and future planning. So that is very day one. Our patients could be very functional. They still be working, they still be driving, but they're already under our palliative team. And then myself and the MND social worker will be going into their home just to introduce ourselves over a cup of coffee, very casual, and make sure that they understand what we can do and we understand what they want and what they fear of. To know about the family, also have a look at the home setting as well. After that, then I will book them into our clinics. Our clinics got no neurologist. Our neurologists, we're still fully dependent on the expert like Professor Keenan and St. Joseph. So all that is continued, the network continued the patients will go back to the neurologist, BMI or Dominic Rowe. But in the same time, they come to us with the clinic of having palliative care consultant as well as a rehab consultant. So we look after really is them as a person in front of us. With or without MND, what you need, we are here. That is what our differences is. And in the palliative care in the clinic, a lot of time we will be starting as how much they know and what is their concern. A lot of them, they will come in with a lot of information being told to them, but that is the time we find out how much they actually heard and how much they want to know in that very moment. Most of them, they will ask questions, probably what they saw on the internet and feel that they're going to be like that exactly in a few months' time. And that is where we used to take the time to explain to them everyone is so different. In rehab, having a rehab consultant is really helpful, and our clinic has been running for 17 years, and Dr. Gardner has been with us for 17 years. That he is so experienced with MND, and he got such a network with the OT, everyone in the team, that he's just able to make sure the patients are safe. And having a palliative care consultant and palliative trained nurse and palliative social worker in the team, that we were able to get into the advanced care plan quite early on, as well as the ethical issue of the difficult decision making for having a pig, not having a pig, having the NIV, what happened at the end with the NIV and the pig. All those feeding, not eating and drinking, the dying process, all that we were able to do that quite early on. In the same time, what we're different is all of us can do home visit. So we actually can have this conversation at home as well. And we can have it repeatedly at home or in the clinic. So that makes it, the quality of the conversation a bit more better, as well as they don't need to take the information home and just leave it there for 3 months review. They can give me a ring 2 days later, or give the social worker a few days later and have the same conversation to go through what is their concern again. So that makes the difference, having the palliative team in the back. So we also have the gym, the outpatient gym, that got physio and is palliative physio as well. Palliative gym in there. And that's the picture there. That you can see from the size of the gym is not very big, and we mix them with all other PALCare patients as well. We don't just have the MND patients in there. We don't tell anyone what they got, but they usually don't know how, they suss it out who got MND, who doesn't. And you can see we do eating and drinking a lot more than moving around in the gym as well. So it's really a social event. And also a lot of patients, they ask about, if I do exercise, I'll be so exhausted because of the MND and the fatigue will kick in. And I can't do anything in the afternoon. Our aim is for them, even just they arrive to the gym, that is the achievement of the day. So you can do anything in there or do nothing in the gym, and that is already what you can do, more than there's nothing else you could do about this anymore, that kind of mentality. And also the carer tend to group together and just sit around or in a coffee group for an hour, hour and a half, just their time, because they know the loved one is in a safe hand doing what they're supposed to do. And also with 18 months ago, we got a grant, pilot trial for hydrotherapy. So in there, everyone was quite not sure how it's going to work. Because one is the risk, also there's no support. It's just the physio and us say, this is one service we wanted to give it to the patient. There's already a swimming pool, empty swimming pool underneath in the building. Why can't we use it? So we just give it a go. And end up really, really successful. I witnessed a young man, a father of 2 and 4, that he actually used a hoist he mobilized with electric wheelchair. He could still transfer, but most of his time is on electric wheelchair. And he used a hoist to go into the gym, to the pool. 3 sessions later, he actually used the stairs to come back out and have a shower before get back to the electric wheelchair. And the feedback is always very positive, and that make us, and actually enough for our manager and the CEO to approve that as a regular program. And we actually increased to 2 days a week. That gave us a lot of confidence, and all because of the patient's willingness and able to come on every week. Also the flexibility of they don't need to sign in every week. They have to for 12 weeks because there's a lot of rehab program. You only got set time. No, this is open, endless. If they can make it, they come. Good that if they can phone us a few days ago that they can't make it or they are too tired because they've gone out, then we can put another MND patients in. If not, then we just spend more time with those who turn up. And this is for the carer as well, because carer have a sore back, sore knee. They also feedback quite positive that they were able to feel a bit better, refresh. So with the activities happening, and with the existing PALCare hospital actually in the background supporting us, we were able to do respite quite easily. Not like people could be found, especially under 65, could find quite difficult to find somewhere to stay for 2 weeks when the carer is actually in the maximums, or the wife got a conference to go to oversee and they couldn't go with them. So we were able to provide respite quite easily, as well as come in for symptoms management for the saliva, for respiratory, for having a sleep study in St. George Hospital, but need a few more days rest and practice, then they can come to us directly from St. George or Sutherland area to stay a few more days with us. And of course, Calvary is famous for that terminal care, that people do come in and go back home. A lot of patients was fearful they come in and never go out, but that is not the case. We actually got more beds for rehab than PALCare. But at the same time, we are very good at terminal end of life, that we make sure everyone is as comfortable as they can be. In the same time, myself as a PALCare nurse, I do home death with them at home. And a lot of time is gone through with BiPAP, with PIG, the conversation of not eating and drinking. The patients without PIG, but not able to eat and drinking very early on before the death, what those conversations is and what those supports, the actual support is able to deliver in that holistic setting. Of course, with the PALK involved, that means the volunteers are involved. All of the MND patients will pair up with a volunteer, sometimes two, one for the wife, one for the husband, and just to make sure that they have enough strength to go on. This is just a summary what I found through the few years with MND, that one patient and family actually to deal with all these people, or mostly in the same times or in a different time. Review, listening to each consultation and try to remember each consultation. Yes, there is a lot of support for them looking at this chart, but for me, also like to look at the other way around. They need to deal with living with MND as well as all of us. That is a challenge that we probably asking for too much. We ask them to do things later on. We're starting to have a coffee group a few years ago. Again, it's just something just chuck out in the air. We worry very much about people in different stages of MND will come in and eyeball others, so the others a lot worse, and they will become very, very sad, not able to face the future. But it's actually proved to be the other way around. They all comes in, eyeball each other's technologies, so what they've got, and they actually met friends. There are so many different age groups. They actually make their own group now. They go outside having lunch. All of them have conversation which areas, which restaurant got the best wheelchair access, which one got the best food, most easier, the best area. And so all that are actually happening because of this group that actually saved me and the rest of the allied health team a lot of time, giving emotional support or giving those, having those conversations, because they were able to make their own network. And while they're facing similar difficulty, especially NDIS, that they were able to talk to each other without us and try to solve some problem without actually need to have myself and a social worker involved. So that comes in really, really positive. And I'd like to show you that that pictures put there for home visit. That is at Meet Peter Kilgarnon, that he actually housebound the last 18 months of his life, looking like that, and on the electric wheelchair with the eye gaze, with the pig, with the BiPAP. Have a very young kids. And during the 18 months, he went out once to his daughter kindergarten graduation. And that was a big deal for that 2 hours just across the road. A lot of conversation, a lot of anxiety, a lot of pre getting him ready mentally, as well as getting the wife to get everything is just in case or what if that kind of conversation happened. And I won't be able to deliver that if I doesn't have the service set up this way. So the home visit really make a big difference. And really, we just all sitting here, and everyone that I work with just want to make sure maximize the quality of life, no matter how long or how short they've got. And I always like this phrase from Dr. Brennan, that is the power care consultant, who highly respect Peter. He mentioned you all the time, that there's always something we can do for them. Thank you very much for your time.